Okay, our next case is a pregnant adolescent with increased blood pressure and swelling. 16-year-old Gravida 1, black female, comes to the outpatient clinic for routine return prenatal visit at 32 weeks. Do you think it makes any difference, Gravida 1? In terms of hypertension, the most significant risk factor for preeclampsia is first pregnancy. First pregnancy. Comes to the outpatient clinic for routine return prenatal visit at 32 weeks, confirmed by 18-week ultrasound. Now, we looked at the accuracy of dating with ultrasound at different gestational ages. Less than 12 weeks, plus or minus 5 days. 12 to 18 weeks, plus or minus 7 days, so it should be quite accurate. Over 2 weeks, she has developed swelling of her face and hands. Now, swelling of the lower extremities is ubiquitous. What's ubiquitous mean? Everybody gets it, almost. Upper extremities, face, not ubiquitous. This is more concerning. Her previous blood pressure was normal, 120/70. No change in mental status, headaches, scotomata, blurred vision, shortness of breath, or right upper quadrant pain. Now, why do you need to ask all this? Mental status, headaches, scotomata, but all that stuff. Because if she has hypertension, and if she has any one of headaches, epigastric pain, visual changes, that moves it into severe preeclampsia. So it's important to ask those questions. Family history of preeclampsia and diabetes mellitus. Exam. Puffy-faced edematous. 7-pound weight gain over 2 weeks. What should she be gaining in weight in 2 weeks? 2 pounds. Blood pressure, 160/90. That's not normal. Fundoscopic exam, vasoconstriction, no exudates. Abdomen benign. Deep tendon reflexes within normal limits. Fundal height is 29 centimeters. She was 32 weeks, 29 centimeters. Kind of borderline. Fetal heart tones, 130 in the left lower quadrant. Now, what do you think that means when you have the fetal heart tones in the lower quadrant? What does that tell you about the orientation of the fetus? Probably cephalic. If the fetus would be breech, you expect the heart tones to be in the, at least that's what we would think of. Cervix is long and closed, membranes intact, no vaginal discharge. All right. Our differential diagnosis, pregnancy-induced hypertension. Now, what are the different kinds of pregnancy-induced hypertension? Transient hypertension, mild preeclampsia, severe preeclampsia, HELP syndrome. Let's go back. What's HELP syndrome? Hemolysis, elevated liver enzymes, low platelets. All right, you got that. My, you're such a smart group. What's the difference between transient hypertension and mild preeclampsia? There's one significant difference. Transient hypertension, blood pressure is up, comes down right away. Mild preeclampsia, severe preeclampsia, it is sustained. We used to use a relative rise of blood pressure in making a diagnosis of hypertension. A rise in diastolic of 15 millimeters of mercury or more, a rise in systolic of 30 or more. That has now been thrown out the window. It is absolute numbers, 140/90 or greater. No relative rise. The key thing here is we want to know, is it a sustained elevation of blood pressure? So the first step is going to be repeat the blood pressure in 15 minutes. We're going to do urinalysis looking for urine protein, hemoglobin, hematocrit, platelet count, BUN, creatinine, uric acid. Sometimes we call these PIH labs. What would you expect to happen with pregnancy-induced hypertension to hemoglobin and hematocrit? They go up, hemoconcentration, because you have decreased intravascular volume. What would you expect to happen with BUN, creatinine, uric acid? You have vasoconstriction, decreased renal blood flow, so you have decreased clearance. BUN will start rising, creatinine, uric acid. Now, what are the normal levels of BUN, creatinine, and uric acid in the non-pregnant condition? BUN up to maybe 15-20, creatinine up to 1, uric acid 7-8. Normally in pregnancy, BUN should be less than 10. Creatinine should be 0.5, 0.6 or less, and uric acid should be 4. So if you have even normal non-pregnant levels in pregnancy, that's high. Let's see what we get. ALT, AST, liver function tests. PT, PTT, looking for any DIC, and urine toxicology screen. Because if she's taking some illegal street drugs, it could cause elevation of blood pressure too. So, repeat blood pressure, darn it, stays up. So we have some elevation, which is persistent. Urinalysis, 3+ protein. What happens to protein in the urine in pregnancy? Does it change? Does it go up, down? Is it normal to have proteinuria in pregnancy? Never normal. Now, glucose in the urine is very normal, but not protein. So this is clearly abnormal. Hemoglobin hematocrit, 1542. That's elevated for pregnancy. Platelets, 230. So that's okay. We don't have DIC, at least from that standpoint. BUN creatinine, look at this. 18. This should be less than 10. Creatinine should be less than 0.5. These are clearly evidence of elevation hemoconcentration. ALT, AST, 2535. Is that okay? That's all right. And PT, PTT, those are within normal. What does it say in the notes? 70. Okay. That will need to be changed. Thank you very much. That kind of got lost there. All right. Urine toxicology, negative. Okay, what's our working diagnosis? Mild preeclampsia. What are the criteria for mild preeclampsia? Blood pressure elevation, sustained elevation, proteinuria, which is 1 to 2 plus, and upper body edema. Further diagnostic plan. Let's look at how the baby's doing. And biophysical profile while we're doing the ultrasound. So what do we find? Single fetus, 31 weeks. How many weeks gestation is she? So the ultrasound shows the fetus is appropriate size. Cephalic presentation is what we thought with the lower quadrant fetal heart. And the fetal heart rate is 145 per minute. Biophysical profile, NST is reactive. Body movement is present. Breathing movement is present. Extension flexion, AFI 11. Are you happy with this? So, mild preeclampsia, remote from term, mom stable, baby stable. What's going to be our management? With mild preeclampsia, less than 36 weeks, fetal well-being, appropriate management is hospitalization and conservative observation. No MAG sulfate. We're going to give IM beta-methasone. Why do we give IM beta-methasone? It's given to the mother, crosses the placenta, stimulates the fetal type 2 pneumocytes to produce surfactant to enhance the fetal lung maturity in case we need to do delivery. And so we will watch. Now, if she is term, what's term? Technically, term is going to be 37 completed weeks. But functionally, what is the last organ system of the fetus to mature? The lungs. At what gestational age does the LS ratio become over 2? Between 34 and 36 weeks. So functionally, we say if she's 36 weeks or more, get the baby out if there's any concern about well-being. So if she was over 35 weeks, we'll go ahead and deliver. Not necessarily a cesarean. Oxytocin would be fine. And induce labor. Now, if she's going to be induced, we would give IV MAG sulfate for prophylaxis of convulsions. But if we're just watching her on the maternity unit, we don't give the MAG sulfate. Now, what is the mechanism of preeclampsia? It is probably prostaglandins. You have a relative increase in thromboxane, which is a vasoconstrictor, and a decrease in prostacyclin. That's probably what is happening. So we admit the patient and we watch her. 1 week later on the maternity unit, at 33 weeks, persistent headache. Now, what's the most common cause of headache in pregnancy? Muscle contraction headache, right? I mean, that's pretty common. This is new onset of headache that she hasn't had before. What else did we find that she's got here? Epigastric pain. What's the most common cause of epigastric pain in pregnancy? Reflux esophagitis. See? But when you put these together with hypertension and proteinuria, it don't sound very fine to me, right? This isn't good. Blood pressure creeping up is now persistently 165 over 115. What is this smelling like? Severe preeclampsia. Severe preeclampsia. AST is now 5 to 10 times elevated. ALT, platelet count. She's got the whole ball of wax here. Headache, epigastric pain, elevated blood pressure. She's got elevated liver function test. She has thrombocytopenia. Not good. Now, what's her cervical exam? 1 centimeter, 50% effaced, soft, -2. Would you call this a favorable cervix or unfavorable? Not very good. Not very favorable. Severe preeclampsia. Only one criteria is needed to make the diagnosis other than the hypertension, proteinuria, and the upper extremity edema. And let's look at what are those single criteria. If she has headache, which can't be explained, even if the blood pressure is, say, 140 over 90, if she has epigastric pain not relieved by antacids, even if the blood pressure is 140 over 90, visual disturbances, which are not usual, severe hemoconcentration, DIC, elevated liver enzymes, pulmonary edema, oliguria, cyanosis, any single one of these, along with a diagnosis of mild preeclampsia, would consider her as severe preeclampsia. And the treatment for severe preeclampsia is delivery. And you will see this a number of times now. IV mag sulfate to prevent convulsions, lower blood pressure to bring it between a diastolic of 90 to 100. And why don't we want to bring blood pressure below 90? Jeopardize the fetal placental blood flow. See? So we want to bring it down, but not too low. And what agents will we use? Hydralazine or labetalol. And the reason we use these is because they will lower blood pressure without decreasing cardiac output. If it's chronic hypertension, our drug of choice would be alpha-methyl-dopa. With severe preeclampsia, hydralazine, labetalol. And we're going to start IV oxytocin and see what happens in the next 6 hours. No routine cesarean. So, aggressive management of severe preeclampsia is MAG, lower the blood pressure with hydralazine, labetalol, and induce labor with oxytocin and amniotomy if needed. So, that's what we're going to do. 2 hours later on the maternity unit, she received a 5-gram IV loading dose of MAG over 20 minutes, and now she's on 2 grams an hour. That's okay. That's the dose that we'd like to see. Her urine output has been 15 milliliters over the past hour. Are you happy with that? What's normal urine output? We'd like to see 750 cc's a day, at least. The oliguria would be less than 750 cc's. So that would be every 8 hours would be 250 cc's, which would translate to how many cc's an hour? 30. So about 30 cc's an hour is what we'd like to see before we say oliguria. She's got 15. Now, if she has decreased renal function, what could that do to her MAG level? It could start to rise because you excrete the MAG right through the kidney. Her respirations, which were 20 per minute, are now 5 per minute. Are you happy with that? I'm not happy with that. Continuous fetal monitor shows a baseline fetal heart rate of 140, decreased variability. Would you be surprised if there was decreased variability from the fetus when there's MAG? This baby is not going to be moving, right? Because you're going to have neuromuscular blocker functioning at in the fetus. No accelerations, but no decelerations. So that looks all right. The main concern I have here is her respirations are decreasing. Our assessment, probable magnesium toxicity. How do you treat this? Administer oxygen wide open, mask, 8 to 10 liters, oxygen saturation monitor, and start IV calcium gluconate. What is the antidote for MAG toxicity? Calcium gluconate. Okay, the next case is no prenatal care, contractions, chronic hypertension. You notice we're trying not to give you a diagnosis because they don't give you a diagnosis on the exam. But just to summarize where we go. 23-year-old multipara, so she's had previous babies, comes to the emergency department at 28 weeks by dates with regular contractions every 7 to 8 minutes. You like this? 28 weeks with contractions. What are you concerned with? Preterm labor. No prenatal care. States fetal movements are present. She's a smoker. One of the risk factors for preterm labor is smoking. She's been treated in the past for chronic hypertension. Her previous pregnancy resulted in a preterm 31-week delivery. Again, risk factor for preterm delivery is a previous preterm delivery. Previous preterm delivery. And I might say that the preterm delivery rate in 2002 is no different than it was in 1902. In fact, it's higher. We haven't been very successful in decreasing preterm deliveries. She denies vaginal bleeding. See, if there was bleeding, let's say an abruption, that could be a reason why she's having contractions. Watery vaginal discharge, premature rupture of membranes could lead to preterm contractions. She's afebrile, stable vital signs. Fundal height is 33 centimeters at 28 weeks. What do you think about that? Called large for dates. Now, what's the most common explanation? Dating error. She's had no prenatal care, so we really don't know. But let's say that she does have correct dates. What could cause the uterus to be large? Think of the fetal compartment of the amniotic fluid compartment. Fetal compartment would be multiple gestation, grande bébé, big baby, polyhydramnios. How would you diagnose any one of those? Ultrasound. Okay, let's have a look. Differential diagnosis. Preterm labor, preterm contractions. Which does she have? You don't know. What is the key element which is missing? It's evidence of cervical change. Evidence of cervical change. See, we don't know whether she's just having contractions or whether the contractions are bringing about a change in her cervix. So, digital cervical exam must be the first thing. Now, so often when I come to make rounds at the hospital and the resident tells me, well, we have a patient who's 32 weeks who's on MAG sulfate 3 grams an hour because she's having contractions. So I say, and what is her cervical exam? Long, closed posterior. Is she in preterm labor? She's not, see. She's having preterm contractions. And yet we treat these patients with all this MAG and terbutaline and stuff. Okay, CBC, urinalysis, cervical cultures, sonogram. Let's see what we find. Cervix long, closed, firm posterior. Is she in preterm labor? There are some patients who are blessed with contractions. From 20 weeks, they just contract and contract and contract, and you have to induce labor at term because they don't go into labor on their own. See? White count 9,000, hemoglobin 9.5, hematocrit 26, MCV 75. What does this suggest to you? What kind of anemia? Microcytic anemia. What's the most common microcytic anemia is iron deficiency. Urinalysis, many bacteria and white blood cells. One of the associated factors with preterm labor is asymptomatic bacteriuria. And she could very well have that. Cervical cultures, we don't know what those are yet, but we got them for gonorrhea, chlamydia, and particularly for group B beta strep, because that's associated with neonatal sepsis. What does ultrasound show? Twins. 28-week twins. cephalic presentation, normal amniotic fluid. So we have a reason why she may be contracting, the twins. We've got another reason, probably asymptomatic bacteriuria, but is she in preterm labor? No. We call it preterm contractions, twins, 28 weeks, iron deficiency anemia, UTI. Management. Observation on the maternity unit for evidence of cervical change. Oral hydration, ferrous sulfate 3 times a day, oral nitrofurantoin. Now, what is the recommended daily allowance for prophylaxis or prevention of iron deficiency? 30 milligrams of elemental iron. That's 1 tablet of ferrous sulfate. With established iron deficiency anemia, you give 3 tablets a day. But giving more doesn't do any, doesn't bring about any improvement because there's a transport maximum of iron across the GI mucosa in the proximal jejunum. And I like to use nitrofurantoin for UTIs because they will have a high efficacy for the gram-negatives, enterics, and there appears to be very little resistance. The other thing is it is concentrated in the urine and doesn't give systemic levels where you have then a yeast infection which results. Yes? Question?
There are many other reasons why the MCV might be involved. I don't know other data here. Should we investigate that before we...
Okay, the question is, if the MCV is low, there are lots of other reasons. Since iron deficiency anemia is 8 times more common, our general approach is we're going to make an assumption of iron deficiency, treat it, and then see what happens. If there is no response, then you may want to go ahead and do your hemoglobin electrophoresis and other stuff like that. But as a general rule, we just go ahead and make the assumption. But you are correct.
For the next step, you would want to do ferritin?
I would not do the ferritin. Basically, what you would do then is just follow the retic count. And if it starts rising, then you'll assume that that's what it was, iron deficiency.
Dr. Scala,
yes.
Would it matter if you did the ultrasound first or the digital cervical exam first, or for the test, should we do it in a certain...
Oh, cervical exam first.
Before the ultrasound?
Oh, yes. Because if the cervix is long and closed, you've got lots of time in the world. If the cervix is, say, 3 centimeters dilated, you're going to move on, right? All right. Clinical diagnosis. These are the 3 criteria for preterm labor. Gestational age between 20 and 36 weeks. If it's less than 20 weeks, what's the diagnosis? Abortion. If it's over 36 weeks, it's not preterm, right? Then we want to have contractions. You can't have preterm labor without contractions. But we're not going to wait until we have them every 2 to 3 minutes. So we say, let's watch for half an hour. If there are 3 contractions in half an hour or more, then we'll call that. But this is really the key. Is there evidence of change in dilation or a single exam 2 centimeters or more? So let's say she comes in and she's 2 centimeters dilated, single exam. That's it. We make the diagnosis and start the medication. Let's say she's 1 centimeter. Many multiparous women will be 1 centimeter from 20 weeks on. So either a single exam, 2 centimeters or more dilated, or a change in dilation and effacement, preferably by the same examiner. Because different examiners can sometimes come up with different results. Okay, so 2 hours later after observation and repeat cervical exam on the maternity unit, now she is 1 to 2 centimeters dilated, 1 centimeter long, soft, mid-position. What was she before? Long, closed posterior. This is a change. Das ist nicht gut, right? This is not good. Contractions are now every 3 to 4 minutes. What's our diagnosis now? See, the key difference is cervical change. Cervical change. That's the key difference between preterm contractions and preterm labor, is evidence of cervical change. So now we're going to be aggressive. We're going to admit to the maternity unit. We're going to rule out obstetrical, fetal, maternal contraindications. Let's just talk about that for a minute. There are reasons why, even though she may be in preterm labor, we're not going to stop it. We've talked about some of these already. Let's take, for instance, obstetrical. Let's say she's got eclampsia. Let's say she has severe preeclampsia. Let's say she has HELLP syndrome. Even though she's got preterm labor, we're not going to stop it because for maternal reasons. Fetal. Let's say we have a bradycardia. We have repetitive late decelerations. Let's say we have severe IUGR. Let's say we have anencephaly. We have renal agenesis. The last one is, well, we talked about maternal somewhat too. Severe hyperthyroidism. Let me give you a multiple choice question. 100 patients come in, meet the 3 criteria that we talked about, and then we look to see, do they have any obstetrical, fetal, or maternal contraindications? How many of those 100 would not have a contraindication? 5%, 20%, 50%. 5%. 95% of patients who have the criteria for preterm labor should not be stopped. Because it's either going to make no difference or it's going to be harmful for the mother. That's why we haven't made a change in the preterm delivery rate. Then we're going to give mag sulfate if she does not have any of the contraindications. We're going to monitor for evidence of toxicity. We already talked about that. Monitor respirations, deep tendon reflexes. IV penicillin G for group B beta strep prophylaxis. And betamethasone, we'll give 2 doses, 24 hours apart. And they're not going to ask you for dosages on the exam. Okay, just to summarize, risk factors for preterm birth. Twins, 50% of twins will deliver before 36 weeks. A uterine anomaly, double uterus, septate uterus, 50% will deliver before 36 weeks. Previous preterm birth, 25%. And then premature rupture of membrane, smoking, and if the cervix is short. These are all risk factors for preterm birth. Now, I hate even to put this on here, but this is all in your notes, but just let's summarize because they could ask you questions on this. What are the main agents that we use for tocolysis? We can use mag sulfate, beta adrenergic agonists such as ritodrine, terbutaline, and you should know that the only agent which has been approved by the FDA for tocolysis is ritodrine. And yet we don't use it because it's so much more expensive, and terbutaline is basically the same in its function. Calcium channel blockers, an example of that would be nifedipine. Prostaglandin synthetase inhibitors, example of that would be indomethacin. Okay, what are the side effects of mag sulfate? Muscle weakness, respiratory depression we talked about, pulmonary edema. Who should you not use it with? Renal insufficiency because the levels will just rise too high. And myasthenia gravis. This patient already had problems with the neuromuscular transmitters. She'll be on the ventilator. Beta adrenergic agonists can cause hypotension, tachycardia. They can also raise the glucose level. And a patient who is a gestational diabetic on diet control suddenly needs insulin. It can drive the potassium intracellularly, so you have hypokalemia, but that is reversible as soon as you stop the medication. And pulmonary edema. We don't want to use beta adrenergic agonists with cardiac disease because if they go hypotensive on you. Diabetes, it'll throw the blood sugars out of control. And if she's got uncontrolled hyperthyroidism, she's already got tachycardia, and you don't want to make the heart rate any faster. Calcium channel blockers, tachycardia, hypotension, myocardial depression. Who would you like to not give that to? Patients with cardiac disease and who already have hypotension. And then the prostaglandin synthetase inhibitors can cause oligohydramnios and intrauterine closure of the patent ductus arteriosus. Now, what would happen there? The fetus depends upon the patent ductus in order to shunt blood by the lungs, because the lungs don't serve any oxygenation function. You close that in utero, that's not good. And the oligohydramnios, that would be a great board question. It decreases renal blood flow in the fetus and causes decreased amniotic fluid. And then necrotizing enterocolitis is more common in preemie babies whose mothers received indomethacin. So we would tend to give this before gestational age of 32 weeks, if we couldn't get any response with the other agents, this would be the last one. But after 32 weeks, we would not use that. Okay, 2 days later on the maternity unit, uterine contractions have disappeared on IV MAG. She's off tocolytics. Are you happy with that? That's good. We were successful. How successful do you think we are in prolonging pregnancy with preterm labor? 24 to 48 hours. All of the studies show that's about all you're going to get. And what is the benefit from 48 hours? The lungs. That's really the main thing. And to transfer the mother to a hospital that has an intensive care nursery. Cervical culture is negative for group B beta strep, chlamydia, and gonorrhea. Urine culture, she did have an E. coli infection. Pelvic exam 12 hours later, 2 centimeters dilated, 1 centimeter long, soft, mid-position. Das ist gut. However, all of a sudden, she experiences a gush of fluid from the vagina. Temperature is normal. Fetal heart tones are 135. Inspection of her external genitalia reveals a wet perineum with fluid that turns nitrazine paper blue. What are you concerned with here? Yes, it could be urinary incontinence, but our main concern is premature rupture of the membranes. How will we differentiate between these two? Speculum exam. This must be your next step in management, a speculum exam. And what are we going to look for on a speculum exam? Pooling of fluid in the posterior fornix. Take that fluid out, see if it turns nitrazine paper blue. And we're going to put that fluid on a glass slide and see if it turns ferning. We will visually assess the cervix through the speculum. We'll do an NST, see how the baby's doing. An ultrasound to see what the amniotic fluid is like. And what do we find? Pooling positive, nitrazine positive, ferning positive. She's got ruptured membranes. She's got ruptured membranes. Cervix looks unchanged. NST is reactive for both fetuses. Ultrasound shows twins, breech cephalic now. So the first one is breech. How are you going to deliver these babies? The first baby is breech, cesarean. If both were cephalic, vaginal delivery. If the first was cephalic, the second one was breech, I asked the mother, what would you like? Because she could deliver the first vaginally and then have a cesarean for the second one. And if she says, forget it, just give me a cesarean. So either way, but if it's both cephalic, vaginal delivery. If the first one is breech, okay. Now, oligohydramnion is for the first fetus. That's consistent with ruptured membranes. This is a nitrazine test. Amniotic fluid is alkaline. It'll turn it blue. However, in pregnancy, with the increased with the increased tidal volume, there is normally a respiratory alkalosis. Women will then adjust for that by kicking out into the urine bicarb, and so the urine becomes alkaline. And if she has stress incontinence, which is very common in pregnancy, and you just put nitrazine paper on the perineum, it could turn it blue, but it's just urinary incontinence. So that's why it's so important to the speculum exam. But if you take that fluid and you put it on a glass slide, urine will not do this. Amniotic fluid will do that. Okay, our diagnosis, preterm premature rupture membranes. Twins, 28 weeks, breech cephalic, oligohydramnios. Management, observation. We're going to observe her and basically leave her put until one of two things happen. If she has evidence of labor, we're going to deliver her. And secondly, if she develops chorioamnionitis. Amnionitis, or I should say infection of the chorion and the amnion. And what are the criteria for chorioamnionitis? Maternal fever, ruptured membranes, no explanation from the urinary tract or the respiratory tract. So it's kind of a diagnosis of exclusion. If you can't explain it from the urinary tract, she has no UTI, and she has no respiratory, but she's got a fever and ruptured membranes. We're going to put her at bed rest in the hospital, bathroom privileges, monitor daily for fetal well-being, decelerations on the monitor, uterine contractions. We're going to give her a 7-day course of prophylactic ampicillin and erythromycin. See, we used to think that the patient ruptured the membranes and then became infected. The evidence is pretty strong. The reason the membranes rupture is because they were weakened by infection. So we prophylactic get on board and get on ampicillin and erythromycin to try to decrease any bacteria which could be present. And then, of course, in her case, because the first baby is breech, we're going to do a cesarean. So, ruptured membranes, pulling positive, nitrazine positive, Ferning positive. The management of ruptured membranes is triaged according to gestational age. And I divide these into term, preterm but viable, and pre-viable. If you have ruptured membranes at term, 36 weeks or more, get the baby out. There's no point waiting around. If it is preterm but viable, what's a viable gestational age? 24 weeks, 23, 25, let's say 24. If you're given an exam question, 24 to 35 weeks, conservative management in the hospital. Let's say you have a case, 19 weeks ruptured membranes. What's the likelihood of getting a viable baby out of this? Not very good. In this case, you could offer to the mother either induced labor, or if she wants to be conservative, there's no point keeping her in the hospital. What if she delivers a 19-weeker at home? What's the difference in outcome of this baby if she delivers it at home or in the hospital? No different. So we would tell her, come back if there's contractions or a fever. So this basically summarizes management of premature rupture of membranes. Okay, so we're being conservative. 2 days later on the maternity unit, that's 7 days after she's ruptured, a routine daily fetal monitor strip is being run to assess fetal heart rate and uterine activity. And you notice repetitive 30-second duration contractions, and with each contraction, fetal heart rate drops suddenly. I want you to notice this word, suddenly. And then immediately comes back up. It goes from 140 to 90 and immediately recovers. So it does what I would call the box. Drops, comes right back up. What is a mechanism of a sudden drop in heart rate? Vagal stimulation. From probably cord compression. Vagal stimulation. What kind of deceleration do we call that? Variable deceleration. Here you got it. The sudden drop, the sudden return. The sudden drop, the sudden return. This is a variable, and we think of umbilical cord compression. So our differential diagnosis here is variable decelerations for cord compression. What would be the worst kind of cord compression? Prolapsed umbilical cord. See, if it was, let's say the cord was being compressed because the baby's shoulder is laying on it, you just change the position and maybe it would relieve. But if the cord is in front of the presenting part, so let's change the mother's position, do a digital cervical exam. Maternal position doesn't make any change. Digital exam, a loop of umbilical cord, you can feel it. What's going to happen to your adrenaline level? What's going to happen to your anal sphincter? It just tightens up. Now what are you going to do? You can feel that cord. Prolapsed umbilical cord. Twins. Elevate the presenting part. Don't grab the cord and say, well, I'll tell what the heart rate is. What could happen to the vessels? They go into spasm. See? So you elevate the presenting part, place the mother in knee-chest position. Butt up in the air, the head down. Take the pressure of gravity away. Administer high-flow oxygen, and whoever is holding the head up, you climb on the gurney, and you will run along with the mother until you get to the operating room. And you stay under the drapes there, and then when it's ready and they're ready to take the baby out, then you come on out. But that's an emergency. That's an obstetrical emergency. And here we've got it, see. Here's the umbilical cord hanging out right in front of the head here. See? So what we want to do is to elevate the head. Don't try to stuff the cord back in, because all you're doing is just hiding it, but it's still going to be compressed, see. You don't want to push it back in there. Okay, any questions on premature membrane rupture? I think if you go through this sequence that I just went through, you've got the management. The key thing is the diagnosis is based upon speculum exam. Pooling, nitrazine, Ferning positive. The management depends on gestational age. Term, deliver. Preterm, viable, hospitalization. Beta-methasone, antibiotics, conservative management. If it is pre-viable, I hope they don't ask you 24 weeks. Ruptured membranes, that's a tough one. We would tend to be aggressive and bring the patient in and do our best on that. Okay, any questions? Okay, group B beta strep. Many places use ampicillin. Doesn't make any sense. The ideal is instead of using a shotgun, use a BB gun. Be as precise as you can. Why use broad spectrum antibiotic when a narrow spectrum? And group B beta strep, penicillin will do it. So penicillin G is really your... Now, if you have a patient who is allergic, of course, that would be different. All right. Next case. Term pregnancy, contractions, minimal dilation. 28-year-old prima gravida, 38 weeks, comes to the maternity unit 6 hours ago, spontaneous onset of contractions. So she's having contractions for 6 hours, cervical exam, cephalic presentation, 1 to 2 centimeters dilated, 50% effaced, -2. Contractions every 3 to 5 minutes, is uncomfortable, and the exam by the same examiner shows just minimal change. Instead of 1 to 2, she's 2 centimeters, 80% -2. Is her cervix changing? Yeah, but it's nothing to write home about, right? Her vital signs are unremarkable. Electronic fetal monitor tracing is reassuring, with baseline of 150, frequent accelerations, good variability, no decelerations. And she's saying, "Doctor, what's wrong? Please do something." Okay, is she in labor? If she is in labor, what stage is she in and what phase is she in? The differential diagnosis is false labor versus stage 1, latent phase. Now, which is it? Let's see. How are you going to see? A tincture of time. Tincture of time. Wait and see. Now, it's interesting. You said walk. There was a nice study done at UC Irvine, just down the road here, where they randomized patients, believe this or not, into walking in the early part of labor versus just sitting or whatever. And which do you think progressed fastest? Didn't make any difference. Now, the labor nurses don't like that because they want to get the patient out and walking around. I'm not sure it makes any difference. But observation, ambulation. And I usually ask the mother, what would you like to do? Okay, let's see what happens. So stage 1 labor may be latent phase. How do you make a diagnosis of a latent phase? How do you make a diagnosis of labor? Contractions at least 3 and 30 minutes and dilation less than 3 centimeters. See, the diagnosis of latent phase is cervix prior to the acceleration of cervical dilation. It's just very slow. And what's happening during this time? The function of the latent phase is cervical effacement, softening, and thinning. It's not dilation. And so there's a lot of things that are happening on the cellular level which you don't see. And then, droop, up things move. See, then you get into the active phase of labor. Right now, latent phase. Dare I? This is all in your notes. Let's look at this. Stage 1 can be divided into latent phase and active phase. Stage 1, latent phase, begins with onset of regular contractions. When do the regular contractions begin? This is a soft call. Some patients will say, I've had contractions for 3 months. And other patients will say, I woke up in the morning, 3 o'clock, contractions started. So that's not always easy to pin down. But the end of the latent phase is the acceleration of cervical dilation, typically 3 centimeters, 3 to 4 centimeters. It prepares the cervix for dilation, and this can be up to 20 hours in the primipara, up to 14 hours in a multipara. Now we get into the active phase. The cervix is starting to accelerate in its dilation. Now we've got some much clearer parameters. It begins with acceleration of cervical dilation, ends at 10 centimeters. In a primip, the first time around, she should go 1.2 centimeters per hour or more, and a multip 1.5 centimeters per hour or more. Okay? So, let's say a patient comes in. She's 4 centimeters dilated. We want her to get to 10 centimeters. 10 minus 4 is 6. Divide 6 by 1.2. 5. You can tell her with some assurance, in 5 hours, you're going to be completely dilated. Let's say she comes in, ruptured membranes, cervix long, closed, posterior, like your nose, firm, long. Do you see what's going to happen with her? She's going to have to go through the latent phase. It may be 20 hours. Should you choose, of course, many patients don't choose to get pregnant, they just get pregnant, and you get pregnant, I pray that you will come in labor and start labor 4 centimeters dilated. Boom. Because you will bypass the latent phase. But ruptured membranes, let's say you've been up all day, you rupture membranes at 10 o'clock at night, you come into the hospital, they start the oxytocin, 15 hours later, 3 in the afternoon, you're now 3 centimeters. You're worn out. Anyway, stage 2 begins at 10 centimeters dilation, ends with delivery of the baby. How long should it take to push the baby out? Less than 2 hours in a primipara, less than 1 hour in a multipara. If she's got an epidural and she can't feel the contractions, she doesn't know when to push, you're going to have to add an hour. So it could be up to 3 hours in a primipara. And then stage 3 is to deliver the placenta. It begins with delivery of the baby, ends with delivery of the placenta. It should occur within 30 minutes. Okay, so we admit the patient and we're just watching her. 4 hours later, she's now 5 centimeters dilated. 100% effaced, -1 station, contractions every 2 to 3 minutes. How does this sound? It's good. She's moving. The external electronic field monitor tracing shows a baseline of 160, normal variability, but rapid drops to 110 beats a minute, lasting 15 seconds, rapidly returning to baseline. What kind of decelerations are these? Variables. From cord compression. Are they of significance? Mild variable decelerations, if they are mild to moderate, no problem. What are severe variable decelerations? Remember the rule of 60s. Last 60 seconds, drops 60 beats a minute, or goes below 60 absolute. So these are mild. You don't need to do anything. The management is going to be change position, but basically conservative. Make sure there's not a prolapse cord. This is just showing you the difference between early decelerations, late decelerations, and variable decelerations. And this blue that I've drawn here is the onset of the contraction and the end of the contraction. Remember all this? With the early decelerations from head compression, the decelerations are simultaneous with the contractions. Notice with the late decelerations, the decelerations are shifted. There's a phase shift to where the onset of the contraction, onset of the deceleration, is late. The end of the contraction and then the deceleration. See, They all shifted. And then variable decelerations, we've already talked about this. These are variable. The main thing is rapid drop, rapid return. Okay, 5 hours later on the maternity unit, she's now 8 centimeters, 100% effaced, plus 2 station, cervical exam unchanged for 3 hours. Now, if she was in the latent phase and didn't change her cervix, would that be a problem? No. But in the active phase for 3 hours, she hasn't changed her cervix. Is that a problem? We've got a problem. We've got a problem. Membrane's intact, epidural anesthetic, external fetal monitor tracing looks good. Our diagnosis, inadequate labor progress. Now, what causes inadequate labor progress? The 3 Ps, the pelvis, the passenger, the powers. Which of those can you change? Can you change the pelvis? No. Can you change the passenger? Can you change the powers? How do you change the powers? IV oxytocin. So, assess quality of contractions. They should be every 2 to 3 minutes in frequency. They should be lasting 45 to 60 seconds, and they should be intensity, 50 millimeters or mercury or greater. And what we find here is there's 2 in 10 minutes, 35 seconds, inadequate contractions. So arrest of active phase, probably because of inadequate contractions. So we're going to do an amniotomy, rupture the membranes, oxytocin. Does that bring about a change? Let's see if that changes. The diagnosis of arrest or prolonged active phase is inadequate cervical change or no cervical change for 2 hours or more. The cause is either passenger, the pelvis, or the powers, but the only one you can change is the powers. So you assess quality of contractions, oxytocin if they're hypotonic, and if the contractions are adequate and she's not progressing, what's your management in the first stage? Cesarean. There's really nothing else you can do. So you give her oxytocin, and now she's 10 centimeters. So it worked. She's 100% effaced, plus 2 station. Contractions are 6 in 10 minutes, and we have bradycardia. What's going on now? Is this an okay frequency of contractions? Too much. We have non-reassuring fetal monitor strip with fetal bradycardia due to hyperstimulation, excessive uterine contractions. What's our management? Shut off the oxytocin. Place a fetal scalp electrode. Contractions 3 in 10 minutes. Fetal heart rate is muy bien. Management, or I should say assessment, hyperstimulation, resulting in bradycardia. There was an appropriate response in labor progress with IV oxytocin, but the excess dose resulted in hyperstimulation, which is now resolved. Have her start to push. And she hopefully will do well.